Good afternoon, everyone. On the 22nd of July, the World Brain Day, as usual. I'm Riyad Guider, first Vice President of the World Federation of Neurology and President of the Strategy Committee on Brain Health.
Good day, everyone. Good day, Professor Riyad Guider. I'm Dr. Iman Qasim, the Secretary General of the African Academy of Neurology, and I'm delighted to welcome you to this joint webinar, AFAN, PAUNS World Brain Day.
Okay, we will have a huge panel today. We will have a renowned speaker, and it will not be very long, so don't be afraid, but you will know what is on the state of the art on access to brain health in African and Pan-Arab regions. Our first speaker, introductions, will be the President of the World Federation of Neurology, Professor Steve Lewis. Professor Steve Lewis, your word of welcome. Thank you.
Good evening. I'm Dr. Stephen Lewis, the President of the World Federation of Neurology, and it is my absolute pleasure and honor to be opening up this wonderful webinar, which is a joint webinar between PAUNS and AFAN devoted to World Brain Day. This year's World Brain Day theme is Brain Health and Access for All. For those who aren't aware, World Brain Day has been going on since 2014, and it is devoted to various topics in neurology, and for the last 5 years or so, World Brain Day has been devoted to brain health. As I mentioned, this year it is devoted to access for all. I'd like to thank, before I go on, Iman Qasim for inviting me to this webinar, and the presidents of PAUNS and AFAN, Amina Gargouri and Lawrence Tucker, and all of the wonderful speakers you'll be hearing from today. The vision for World Brain Day Access for All is simple. There are 4 tenets which are easily stated, but certainly not easily achieved. And those 4 tenets are that every person deserves access to high-quality neurological care. Every healthcare professional deserves access to high-quality education and training. Number 3, every country deserves the opportunity to build strong neurological services. And number 4, brain health is a fundamental human right, not a privilege determined by geography and income. So with those basic tenets in mind, I look forward to a wonderful webinar this morning, looking at our problems with access, potential solutions, and together we'll find a way to make brain health access for all a achievable goal. Thanks so much and have a wonderful webinar. I look forward to the rest of the presentations. Thank you.
Thank you very much, Professor Stephen Lewis. And on behalf of the AFAN, I would like to thank the World Federation of Neurology for the support to the African neurology and also for promoting the brain health. And now I would like to introduce the President of the African Academy of Neurology, Professor Lawrence Tucker. The floor is yours.
It is a great privilege and pleasure for AFAN to share the platform with PAUNS again today on the occasion of the 2026 World Brain Day. The topic of access to neurological care could not be more pertinent for our 2 organizations. National member societies of both AFAN and PAUNS face similar enormous challenges, which include high burdens of both communicable and non-communicable neurological disease, regional conflicts and large populations of internally displaced persons, and a paucity of neurologists, as well as poorly functioning healthcare systems. Importantly, PAUNS and AFAN have common interest in neurological service delivery in Africa, because 7 African countries are members of both of our organizations. At present, Africa is experiencing the world's most dramatic increases in both communicable and non-communicable diseases. And this has serious implications for brain health across our continent. The burden of communicable neurological diseases such as HIV, malaria, tuberculous meningitis, and measles encephalitis has increased dramatically over the past year, largely due to the collapse of the international foreign aid funding structures. At the same time, non-communicable neurological diseases such as stroke, dementia, and epilepsy are on the rise as Africa's young population ages and becomes more urbanized. This will become a serious issue in the years ahead. Africa is the largest continent and the most populous region in the world after India and China, with an estimated population of 1.6 billion people. And yet Africa is the poorest continent by far, representing only 3% of the world's GDP, with 22 of its 54 countries classified as low income by the World Bank. Furthermore, there is, on average, only one neurologist to serve every 10 million of Africa's inhabitants. And these neurologists are unequally distributed, mainly in cities and in upper middle income countries. In fact, 10 African countries have no neurologist at all. In other words, the majority of Africans have no access to neurological care. So the challenges facing our respective organizations are considerable. AFAN is meeting these challenges head on, assisted by the 5 principles of the International Global Action Plan for Epilepsy and Other Neurological Diseases, also known as IGAP, which was unanimously adopted by the World Health Assembly in 2022. IGAP has 5 primary guiding objectives: prioritizing brain health policy, improving diagnosis, treatment, and care of neurological patients, promoting prevention of neurological disease, encouraging research and innovation, and importantly, promoting a public health approach to brain health service delivery. In line with these principles, AFAN lobbies for the promotion of brain health with the WHO, the G20, and politicians across the continent. AFAN is also particularly committed to neurological education and training. As Nelson Mandela once said, education is the most powerful tool we have to change the world. With this in mind, and in collaboration with AFAN's international partner organizations such as the WFN, the EAN, the ILAE, and MDS, it runs biennial joint congresses with its national African neurological societies. For example, this year, our AFAN Congress will take place jointly with our Ethiopian colleagues in Addis Ababa from the 20th to the 22nd of November, and we hope that many of you will attend. AFAN also runs fully sponsored biennial regional training courses for neurology residents from lower middle income countries across our continent, as well as online training programs such as our 6-month web-based EEG online training course. Today's joint AFAN and PAUNS seminar represents only one aspect of our 2 organizations' common commitment to neurological education and advocacy for brain health. And on that note, I thank you for attending this seminar, which I'm sure you'll find both enjoyable and enlightening. Thank you.
Thank you so much, Professor Tucker. Brilliant as usual. It's now my pleasure to introduce Professor Amina Gargouri, the President of the Pan-Arab Union of Neurological Societies. Professor Gargouri is Professor of Neurology dedicated to epilepsy and neurophysiology, and she is also working a lot on brain health access. Professor Gargouri, the words of welcoming.
Thank you, Professor Guider. Dear colleagues, distinguished speakers, good evening and welcome. On behalf of the Pan-Arab Union of Neurological Society, it's my great honor and privilege to welcome you to this joint webinar organized in collaboration with African Academy of Neurology to celebrate World Brain Day 2026. I extend a very warm welcome to our colleagues from across the Arab world and Africa, and sincerely thanks our distinguished speakers for accepting our invitation and generously sharing their expertise with us today. As the regional voice of neurology in the Arab world, PAUNS brings together 20 national neurological societies. representing more than 417 million people. Our mission is to advance neurological care, education, research, and advocacy by fostering collaboration among our member society and strengthening partnership with regional and international neurological organizations. Today's webinar reflects this mission. I also illustrate the growing partnership between PAUNS and AFAN, two neighboring regions united by common healthcare challenges and a shared commitment to improve brain health through education, scientific exchange, research, and regional cooperation. I would like to express my sincere gratitude to World Federation of Neurology for its outstanding leadership in promoting global brain health and for bringing the neurological community together every year through the World Brain Day initiative. This year, the theme is Brain Health Access for All. This message is particularly relevant for our region. The Arab world includes countries across the entire economic spectrum, from higher income countries with highly specialized neurological service and access for highly advanced technology, to lower and middle income countries where neurological care remains constrained by shortage and trained professionals, limited diagnosis and therapeutic resources, inadequate infrastructure, insufficient health insurance coverage, and financial barriers. Similar disparities are also observed across many African countries. These inequities are especially concerning given the rapidly increasing burden of neurological disease. Today, approximately 70% of the global burden of neurological and neurodevelopmental disorders occur in the low and middle income countries. Stroke, migraine, and dementia alone account for more than 70% of global neurological burden, while their contribution to disability adjusted life years has more than doubled since 1990. At the same time, demographic changes are reshaping our healthcare needs. In the Arab region, around 6% of the population is now over the age of 65, resulting in a steady increase in neurodegenerative disease and age-related neurological disorder. Despite these growing needs, only 28% of low-income countries have a dedicated national neurological policy, illustrate the significant gap between disease burden and health system preparedness. I would like to express my helpful appreciation to our colleagues at AFAN, particularly Professor Laurence Tucker and Professor Iman Qasim, for their outstanding collaboration in organizing this event. Finally, I would like to thank all our speakers, moderator, participants, and partners for their commitment to this important initiative. Thank you very much, and I wish you all an excellent webinar. Thank you.
Thank you very much, Professor Gargouri. And now we'll start with the first session.
This first session, Iman, will be a session with two outstanding speakers, Professor Francis Pate and Professor Abdallah El-Asmi. They will be presented and moderated by Professor Gargouri and Professor Laurence Tucker. Please.
Many thanks, Riyad, and many thanks, Eman. It now gives me a great deal of pleasure to introduce my good friend and colleague from South Africa, Patty Francis. She is the president of the Neurological Association of South Africa. This is her second term, as well as the president of the Stroke Society of South Africa, and is on the steering committee of the Angels Stroke Society. Patty works as a private consultant in general practice at Umhlanga Hospital in Durban. She has a particular interest in stroke and setting up stroke units, but she has broad interests in epilepsy and headache as well. Patty will speak to us on the topic of access to neurological care in Africa with an emphasis on stroke. Thank you so much, Patty. Will you go ahead?
Good day, colleagues. Today we'll be sharing a little bit on the World Brain Day theme for 2026, which is brain access for all. According to one of the chairpersons of the World Brain Day 2026, Professor Tissa Gujaratni, World Brain Day 2026 focuses on one of the most defining challenges of our time, which is the problem of making brain health accessible to everyone, everywhere, in a timeous fashion as well, because access delayed is potentially access denied. The scale of the problem globally is that there's an estimated 3.4 billion people affected, comprising 42% of the global population, by a neurological condition, which makes brain disorders the leading cause of disability and ill health worldwide. Neurological disorders are said to claim 11 million lives annually, and striking is the statistic that 81% of these deaths occur in low and middle income countries where access to care is most limited. And on average, these patients can face up to a 5.5-year delay between their first symptom and a specialist diagnosis, leading to most commonly irreversible neurological impairment. The other interesting fact about this problem is that the bulk of the projected neurological burden of disease is not due to infections, which the LMICs are commonly known for, but to non-communicable diseases, namely stroke, dementia, epilepsy, and other neurodegenerative syndromes. The concept of access to care implies that care actually exists and one needs to facilitate access to them. The WHO recommends that there should be at least one neurologist per 100,000 population, and the number of neurologists in Africa lags miserably behind the other WHO regions. The median number of neurologists per 100,000 population in Africa is estimated to be 0.03 compared to almost 5 in Europe. With health financing systems, lack of qualified staff, and lack of societies, professional societies, that is, being some of the key drivers of this discrepancy and deficit. There's also a lack of nurses, specialized neurological services such as EMG, EEG, radiology, stroke units, and neurological rehabilitation. This article was published in 2022, and there were a few publications in the last decade counting the number of neurologists in the region. I chose this one because it was driven largely by personnel from sub-Saharan Africa with support from the globe. It was a questionnaire-based survey, and it's noteworthy that 74% of the respondents were neurologists and 76% were from public hospitals. So one can assume it's a fair representation of the hardest hit regions, but with the information coming through from neurologists themselves. So the countries were divided into 4 regions based on the number of neurologists, with level A being greater than 200 neurologists per country, level B being 31 to 200, level C 1 to 30, and level D having 0 neurologists. It was noteworthy in this paper that the majority of neurologists are concentrated in capitals, with a ratio of neurologist in capital to neurologist in country ranging from 0.6 to 1. And in 13% of African countries, neurologists can only be found in capitals. This map nicely depicts the findings of that study, with the red country referencing Egypt, where they have more than 1,000 neurologists, so they are comparable to countries in other regions that are better off, and then Algeria having between 200 and 1,000 neurologists. But I want to point out that the lowest part of this table shows the color green, and there are 5 nations that have 0 neurologists, and then the turquoise, blue, and the yellow refers to countries that have under 30 neurologists, with the singular pink region having between 31 and 50, and then fewer countries throughout having, up to 200 neurologists. 27 out of the 54 countries sampled had less than 50 neurologists. And if we think about the populations of these countries as well as the ratios recommended by the WHO, then we can see that there are problems. So in this milieu, we pause to ask ourselves, would stroke being the major non-communicable cause of death and disability, as well as being front-loaded with the maximal disability and the maximal economic impact on the household occurring at the outset of the disease, with some slow recovery thereafter with rehabilitation? Is stroke treatment possible in this context of sub-Saharan Africa, or is it a pipe dream? Well, we know about primary prevention. We know that up to 90% of strokes are due to modifiable risk factors, such as hypertension, and there are many programs, one of which is the HEARTS programs, that attempts to perform primary prevention attempts on large communities, controlling these modifiable metabolic diseases, as well as lifestyle, as well as diet, and taking into consideration additional stroke contributors like air pollution, etc. However, when it comes to acute stroke treatment, the science is there, having had landmark trials starting in 1995, where alteplase became standard of care for acute strokes in up to 4.5 hours of presentation or 4.5 hours of onset. And then by 2025, we had clear evidence for thrombectomy. I'm not going to say too much about thrombectomy because even in the best centers in the world, with better economies, thrombectomy is not available to all, but certainly thrombolysis with alteplase and now more easier to use tenecteplase, I think this is a goal that we in sub-Saharan Africa can aim for. The most important contributor to acute stroke care has been the concept of stroke unit development. So stroke units are important, thrombolysis is important, and as already mentioned, thrombectomy is important. There's level 1A evidence in the guideline recommendations from the ESO and the American Heart Association that the use of specialized stroke care in dedicated teams improves outcomes in patients, and similarly, the use of standardized stroke care order sets or protocols is recommended. It is well established that death is reduced by 14% and death or dependency by 18% simply by placing patients with strokes in a dedicated area, a dedicated space that is designated a stroke unit, irrespective of their age, their gender, or the severity of the stroke. Simply involves beds, protocols, nurses that are trained to follow specific protocols, non-invasive monitoring of blood pressure, temperature, heart rates, heart rhythms, and oxygenation, and neurological monitoring using the scales of the NIH-SS, the MRS, and the GCS where applicable for hemorrhagic strokes. So what are we actually doing? As I've already mentioned, ECGs, heart rates, blood pressures, respiratory rates, oxygen saturation, temperature checks, glucose checks, in an attempt to prevent or treat complications, provide the acute stroke thrombolysis where possible, identify stroke causes, that's towards secondary prevention, provide early mobilization, rehabilitation, and prevent secondary strokes or infarct progression or recurrent events while the patient is in there. I've paused to read out this list and detail it because in any healthcare setting, this is what nurses are doing anyway for patients. So the personnel make up the stroke unit, and the key important driver of any stroke team is the person who's championing the whole protocol system. Where neurologists are available, it would be a neurologist with training in stroke care. There are many hospitals or many centers that have physicians. Some people have neurosurgeons. Some people have highly trained family medicine practitioners who are GPs that have gone on to specialize further. But there's one champion with nurses that work in close collaboration, following on those protocols that I've outlined, and then the minimum of a physiotherapist, a speech and swallow therapist, and if a speech and swallow therapist is not available, then the nurses, the doctors, the physios all learn to do the initial swallow assessments and the protocols that are necessary for preventing aspiration. If a neurosurgeon is available for the ICHs, well and good. If a cardiologist is available for looking for contributors to stroke, such as rhythm disturbances, well and good. But you need one very skilled clinician in examining stroke patients. Radiology, usually the clinician interprets the radiology, him or herself. Nurses, physiotherapists, speech and swallow therapists, that's the core of the stroke unit personnel. I've already mentioned this. Okay, once again, this is just repeating that it's simple to do, but organized and structured. The scales that we use, the clinical scales, are the NIHSS, which is used by the doctors, and the MRS, which is used by the therapists. Stroke unit care looks at fever, indicating aspiration pneumonia or UTI, which are the two important infections that contribute to poor outcome. Looking at sugar, it is well known that elevated sugar levels can worsen stroke recovery, and then swallow care or swallow assessments because of the major risk of aspiration in patients with strokes. So taking a look at South Africa, these statistics from the WHO for 2021 revealed that stroke was the fourth leading cause of death, following on from COVID-19, TB, and HIV. So if we remove COVID-19 from the equation, since the pandemic is now over, we can consider that stroke would be the third leading cause of death according to the South African statistics. And if we look at the female population, stroke was the second leading cause of death, and there's a number of reasons for why this would be the case. In 2012, which was 14 years ago, there were possibly 10 acute stroke active centers in South Africa for a total population of about 59 million, divided into 9 provinces. And KwaZulu-Natal is the province in which I work, and we have a population of about 12.5 million, with one tertiary referral hospital, which was dedicated mainly to investigation of young strokes due to infections, cardiac causes, autoimmune disorders, etc. So if we looked at what we needed to cover our country adequately for stroke care, we needed at least 250 stroke-ready, stroke-treating hospitals, and at least 57 comprehensive stroke care centers offering thrombectomy, with about 95 emergency medicine services to service that population. And as I say, in 2012, we didn't have much happening. But a few people that were interested in stroke care started a conversation in my office, and we birthed the My Stroke South Africa project. And the first registry for the project was devised by Prof. Alan Breyer, Kath Bateman, and Naeem Bray. And Boehringer Ingelheim heard about our initiative and then captured the idea, and it is now the Global Angels Initiative, with the data being captured in the rescue registry. So what did we do? We came up with principles for our team, which was principle number 1. If you want to do acute stroke care, you must be willing to drop what you're doing and go to the patient immediately, because time is brain. You have to stick to the guidelines. There's no need to reinvent the wheel. There are excellent guidelines that have been drawn up by the World Stroke Organization, the ESO, and the AHA and ASA. And so we take the guidelines and we ratify it for our local parameters with the things that we may not have, but we stick to the guidelines. We were aware that there will likely be complications. We were aware that we must not promise what we cannot deliver, such as thrombectomy, when we don't have it available 24 hours a day. And we must measure our work with integrity, and the weekly team meeting, the multidisciplinary meeting, is mandatory. This is the entrance to our emergency department. This is standard emergency beds in the trauma unit. We have all the examination tools in a stroke bag or a neuro box. That's the corridor down to radiology. We'd get the patient there to do a CT scan or an MRI. And so the stroke unit in real life, without any of the bells and whistles that might be available to the high-income countries, is a group of individuals with the right skills and the right tools and an accountability to the person in charge. So while only 3% of the global population have direct access to a neurologist in Africa, 72% have access to mobile networks, which creates an immediate pathway for education of the professionals, the Be Fast messaging for stroke symptoms, and advocacy. There are programs that are currently run by the WFN, such as at the University of Zambia, where neurologists from the USA come and assist with teaching. And there's other educational activities, such as the training centers from Cape to Cairo, etc. These are still limited in their ability to who they can reach. And so I want to recommend, particularly in the area of stroke, that people go onto this website, the Angels website. It is completely free. There's resources with modules for nurses. There's resources with modules for clinicians. There's resources with modules for the emergency medical services. All the personnel have to do is go onto the site, register, and they can upskill with all the courses, and the courses are updated right up to the present minute with the current evidence base. So it's really a bit of a no-brainer. This tool is available to the world. And so far, having used the registry, South Africa has come a long way. In the interest of time, I'm not going to talk through this summary slide here. And I want to also bring up the free resource of the Fast Heroes, which is teaching school children in primary and middle school about strokes. Once again, it is a completely free resource. There are no costs at all. The materials, the books, the posters, the interactive ebooks, the training staff, they will come to the schools. They will train the teachers and the learners. They use these cartoon characters to teach about the FAST, etc. And they teach them the local numbers that they need to dial if their grandparents are developing strokes. So this is another website to take down, and the telephone number and the social media sites, because we all are aware of the butterfly effect, and science has shown us that the first movement starts off an amazing ripple effect that can really transform the lives of millions of patients that have strokes and other neurological disorders. Thank you again for this opportunity.
Thank you, Dr. Patty Francis, for your excellent and comprehensive talk. And now we move to the second presentation, will be made by Professor Abdallah Al-Azmi. Professor Abdallah Al-Azmi is a professor and senior consultant neurologist at Sudan Kobos University Hospital of Oman, where he served as head of neurology department of medicine, College of Medicine and Health Science in Sultan Qaboos University. He trained in neurology, clinical neurophysiology, and epilepsy at McGill University, Canada, and has played a key role in the development of neurological service and academic training in Oman since his return in 2002. His clinical and research interests included epilepsy, multiple sclerosis, and general clinical neurology, with more than 100 peer-reviewed publications. He is Program Director of Neurology Residency Training Program, Director of the Examination Office at the College of Medicine and Health Science, and Treasurer of the Oman Neurology Society and Oman Epilepsy Society. Dr. Abdallah, the floor is yours.
Hello, everyone, and thank you for joining this World Brain Day 2026 on access to care. The title of my talk will be on primary care and neurology, building the workforce for universal brain health. Let me start my presentation with this question. If you or someone you love had a stroke or a seizure tomorrow, who would you see first? And another important question, that person, would they know what to do? Here is the reason of the importance of this question. 43% of the world population lives with a neurological disorder. So neurological disorder really are not rare. So what is the scale of this problem? Neurological disorder burden span the whole lifespan, from prenatal to early childhood to even old age. The burden is, even though universal, however, it is not uniformly distributed among high-income and low-middle-income regions. It is not just a health problem. It is also an economic one. In USA, the 9 most prevalent neurological disorders cost around $800 billion per year. And if you combine it with mental disorder, the bill goes up to $1.5 trillion a year. And these are most probably still underreported figures. So who's going to take care of all these neurological disorders? This is a chart showing distribution of neurologists per 100,000 people in several countries. For example, in Russia and US, around 5 per 100,000 people. In Brazil, it's around 2.73, and the number really goes down in other countries. You've noted that there is a approximately 60-fold drop from the top to the bottom of this chart. And even if you take an example of the Brazil, which really they have doubled the number of neurologists in a decade from 1.37 to 2.73 per 100,000 people, still there is a persistent economic gap remain between richer and poorer regions. In Africa, the ratio is even worse. There are more than 10 African nations with no practicing neurologist at all. And if you take an example of Zambia, in 2018, there were only 4 neurologists practicing in one hospital, serving around 18 million people. So, this is the second point I want to make. This is not just a funding problem, it is a workforce problem, and specifically a geographical problem. Wherever the burden of neurological diseases is highest, specialists are usually somewhere else. By 2050, half of the population of low and middle income countries will still be living in rural areas compared to the high income countries. And there are other issues these rural areas, especially of the low and middle income countries, are facing. Gaps in electricity access, low health budget allocation, and no dedicated neurocritical units. If we take epilepsy as one example, the treatment gap, more than 75% of people living in low and income countries suffering with epilepsy are not actually receiving the required treatment. In rural India, up to 90% have treatment gap compared to 22 to 50% in suburban and urban India. However, this is fixable. An example of one 22-year rural training program cut the local treatment gap from 90 to 45%. Similar situation also exists in our own region. This is a survey conducted in Saudi Arabia across all 13 regions, where 82 pediatric neurologists were surveyed. And the conclusion of the survey revealed a workforce remain below the international benchmark of 0.4 per 100,000 children. And as expected, the practitioner cluster heavily in big cities like Riyadh and Jeddah, leaving peripheral region underserved. So where does that leave us? I want to make a case that primary care isn't a lesser substitute for this problem. It is a necessary bridge. In fact, there are already a framework for this. Prevention neurology. It splits into universal prevention, population level measures that reach everyone, and selective prevention, where targeted care for individual and high-risk group delivered at the clinic level. The Lancet Commission estimated 40% of dementia cases are potentially preventable through risk factor modification. And we really don't have to build this from scratch. The WHO IGAP ties country-level primary care workforce plan to global target. National plans and public awareness campaigns are recognized IGAP priorities. Headache disorders show how IGAP translates into a strategy for one specific condition. So, does any of this actually work in practice? Let us look at some of these models. The Zambia model, which is very close to our specialty in neurology. As we mentioned earlier, there were only, in 2018, 4 adult neurologists serving 18 million people. What they found, the waiting average time to see a neurologist for the first consult was around 2 months. And they had to spend 4 hours in the clinic on the visit day. They found the 3 top outpatient diagnoses were epilepsy, headache, and stroke. And what they are proposing is to shift some of the stable patients for follow-ups and medication refills to nurses and paramedics. Another example is in South Texas, Project ECHO pilot, a 4-weekly, 90 minutes virtual session on nutrition and brain health, delivered to 13 primary care clinicians serving Latino older adults. It was a success program where self-efficiency rose significantly on all 8 measured items. In fact, more than 90% participant satisfaction, and also the clinician reported that they are intended to integrate brain health counseling into their practice. However, I want to be honest about the risk as well. A global survey of neurosurgical task shifting found that 42.6% of low and middle income countries already have some form of it happening. However, based on the respondent, only 11% believe that training is actually structured. And less than 10% of the providers were able to pursue continuing education. And unfortunately, only 3% received any pay for this important work. So, task sharing works, but only when it is built with training, oversight, and properly financed, and should not be left informal. It is a patient safety risk. Another working example comes from Netherlands, the Parkinson Net, which connect community clinicians with very specialized center for Parkinson disease through well-structured referral and ongoing mentorship, and not just one-off specialist visit. This is a working picture of what a mature referral mentorship pillar can look like once it's fully built out. Which brings me to the 4 pillars I think we actually need. This is the core of it. 4 pillars for building this workforce. First, curriculum integration. The the WHO 2022 definition of brain health span across cognitive, sensory, social, emotional, behavioral, and motor domains. These should be part of our training needs, and they should reflect in the curriculum we're going to develop. The University of Bern already have an existing and awarding certificate of advanced students studies in brain health, which was launched in 2024 and being supported by the European Academy of Neurology and aligns with the Swiss Brain Health Plan. They have also proposed 4-year unified brain medicine residency. However, it's not yet piloted. And for the non-Western examples, we have the African Academy of Neurology's regional mentorship networks, and also India's NIMHANS-led integration model point the same direction. Second, referral and mentorship network. We talked about the mature example of Netherlands in Parkinson Net. Also in Myanmar, they have an outreach model of pediatric neurologists where there is a structured outreach plus telemedicine. In Germany, we have an example of Tempest telestroke, where they connect more than 3,000 patients, of which 63% treated within the network hospitals, with measurable better outcome at 3, 12, and 30 months than rural areas which are not part of this program. Third, continuing education and decision support tools. There are already named structured courses built specifically for non-specialists. Examples include emergency neurological life support and the comprehensive neurocritical care courses. We talked about the ACO-style tele-mentoring as a scalable delivery mechanism for ongoing training, not just one-time course. Also, examples like mobile stroke unit, they cut treatment time by average of 40+ minutes. Decision support bringing the point of care, not just in the classroom. And fourth, the one that makes the other three sustainable, policy and financing. The Mozambique Technician Surgery Program is the clearest example where formal Ministry of Health recognition gave a mid-level surgical cadre defined scope of practice, regulated training, and appropriately financial compensation. And this led to improved workforce retention. The European Academy of Neurology already published their 16 concrete recommendations, mapping across these pillars. And the American Academy of Neurology's 2050 vision, a brain health visit, is just a standard part of routine primary care. So, here is what I am really asking of each of you. If you are a decision maker, then please fund and formally endorse task sharing structures, training, scope of practice, appropriate compensation, and not just pilot program. If you are part of a professional society, then build the training, mentorship, and referral network, which we talked about them today. And please advocate the implementation of the IGAP in your local country. If you are a patient or a member of the public, then know the warning signs and treat primary care as your first trusted point of contact, not a waiting room before the real care starts. So to conclude, brain health is a human right, but that's only true in practice if the workforce exists to deliver it. My ask is very simple. Support integrated training and local IGAP implementation, starting with your own institution. As the American Academy of Neurology put it in their own calls to action, we call on neurologists and other stakeholders to use our collective efforts to make this vision a reality. Thank you.
Outstanding first session, as you have seen. And now we go to the second session with two presenters also.
So we will have Dr. Michel Arnaud-Safoudaman from the Gabon, and then our friend Professor Hatem Semir from the Egypt.
And we will have also, as usual, Professor Gargouri and Professor Tucker, who will present them and moderate the session. Please.
Many thanks to the speakers of the first session, Dr. Patty Francis, of course, and Professor Abdallah El-Azmi. It now gives me pleasure to introduce the first speaker of the second session, Dr. Michel Arnaud-Safoudaman. Michel Arnaud is a prominent Gabonese neurologist, neuropediatrician, and clinical neurophysiologist. He is Director General of the Melon Regional Hospital Center and Assistant Professor of the Faculty of Medicine of the University of Health Sciences in Libreville. He is also Vice President for Central Africa for both the African Academy of Neurology as well as the African League Against Epilepsy. He will be talking to us about telestroke across borders, digital solutions for better brain health. Michel Arnaud, please go ahead.
Good afternoon, ladies and gentlemen. First of all, I would like to thank the organizer of the PAUNS Committee Organization and also AFAN. Gave me the opportunity to make my talk this afternoon on telestroke across border digital solution for better brain health, a regional strategy for equitable, rapid, and connected acute stroke care. I'm Michel Arnaud-Safoudaman. I'm a neurologist from Gabon. I'm also as it has been said, I'm Vice President of AFAN for the Central Africa region. I have no conflict of interest to declare, and this is my layout. A quick background. Time is brain. Indeed, time is brain. It has been demonstrated that approximately 1.9 million of neurons are lost each minute in stroke non-treated. Then time is brain guides every stroke protocol worldwide. But specialist access across our region remains deeply uneven. And even to achieve repair fusion in 4.5 hours, an IV thrombolysis should be done. In 24 hours, an extended window is open for select thrombectomy cases. What telestroke brings us is to reduce less than 28 minutes the average cut to treatment in case of stroke. Why this is important? Because stroke is shifting from a disease of aging to a disease of young adults, mainly in our region of Africa and Middle East Africa. The causes remain the same: hypertension, obesity, but also the rapid epidemiological transition. Paris and Falatafi shows that from 1990 to 2021, the increase of incidence were up to 100. But the age rate average were less higher. Here, you can see that for people above 70, ischemic stroke are more common than hemorrhagic stroke on the left side of the screen. But the right side shows the years of lost life compared to years lived with disability. We see that the disability is still low, is indeed becoming higher with the age, but What is increasing is the lost life of patients, which is becoming very, very important after the age of 69, something like that. Where are we right now? We are in a situation that neurologists are more important in terms of number in countries, but they remain in main cities, leaving then rural, remote, and cross-border population without timely access to expert care. Access to vascular neurology. Many secondary hospitals have no on-site stroke specialist day or night, and patients in border and rural areas face long transfer times to the nearest stroke-ready center. What is known is there is less than one neurologist per million of population. This is far below WHO recommended density in our region, Africa as well as Middle East. Neurovascular units are less than 70 in the 67 countries of our region. So saying that, it's important then to think about developing telestroke. What is a telestroke? Multidisciplinary care team for access to rapid care in case of stroke. This team includes a medical subspecialist, indeed, a primary care physician, a health plan, information and technology developer, and policy makers, with a simple target: increased care, increased thrombolysis, increased cost effectiveness, increased equity, and reduce treatment delay and stroke mortality. A telestroke, it's a hub and spoke model that connects a stroke specialist at a comprehensive stroke hub to a patient at any partner site in real time by video and share imaging. There is approximately 254 network worldwide, and it is designed like that. At the very beginning, it was what we see on image A. There's a hub linked with main spoke hospital, and after that, there were a hub and a spoke hospital and a traveling stroke expert, which is not necessary in the hub hospital, but at the hub hospital, we have a specialist who is connected with the spoke hospital. After that, we went to kind of phase 3 hub and spoke hospital, including a World Web device. Then a spoke hospital putting everything concerning patients in the web, in the cloud, linked with a hub hospital and a remote stroke expert, not necessarily within the hub hospital. And then the last upgrading was including a mobile emergency system. Here under the red cycle, it's what might be applicable or sampling for our region. Spoke hospital in province, across border, with worldwide web facilities, hub hospital, and remote stroke expert. Then, telestroke is more than a simple video call. It's an ecosystem of connected technologies working together in the acute window. First, video consultation, in real-time examination, and NIHSS scoring with a remote vascular neurologist. A mobile stroke unit, CT-equipped ambulance that began treatment before hospital arrival. Cloud-based PACS, this is important. Instant sharing of CT, MRI imaging across site and borders. Mobile wearable alert, it's a pre-hospital symptom recognition and rapid EMS notification. Also, AI-assisted imaging, automated large vessel occlusion and MRI detection to speed triage, and share care pathway, unified protocols and registries linking every node in the network. This is an example of a telestroke unit. Is actually an exercise in in United States. We can see there is a patient with a stroke, let's say with left limb weakness, left body part weakness. Along to a patient, there is an on-site physician, which is supposed to be non-neurologist in the stroke hospital. And here on the screen, there is a neurologist. The neurologist will guide the on-site physician to make the assessment and then send the patient to scan, and then the CT will give a result, aiding help with AI and so on and so forth, have a diagnostic as soon as possible, and then be eligible for thrombolysis. Telestroke has been proven to be benefit for stroke patients in remote location. And after COVID, North African region and the different areas around the world have started to also set in place some facilities. And key assumptions for the implementation of telestroke services have been made by Rizwana and collaborators. The assumption was a completion timeline, use of existing consumable and equipment, preparedness of physicians to operate the system in a remote area. What completion timeline means? It means that before starting the project of telestroke, we should be sure that software is available and it will continue to work as a regular service. Also provide several lectures to specialists at peripheral sites. We should also be sure that the manpower is available. And the only remaining issue is making the telestroke software system available. Then, if the step 1 is reached, the step 2 will be easy to do, and then we get to the step 3, educate the emergency department physician and the nurse in the peripheral hospital regarding the telestroke service. This is easy to be done because in our remote hospital, we have people there. We have physicians, we have nurses. What we need then is the device, the software, the camera, and also internet. I wanted to share with you the roadmap of telestroke in Canada. It's a virtual stroke care services identified. Here in the emergency telestroke, let's focus on technology and clinical readiness. Technology, point-to-point network connectivity, diagnostic quality, and physician-tested equipment, on-demand service, broad solution, data security and privacy, diagnostic images, sharing solution. Clinical readiness, training of all clinical and technical staff across disciplines. On-call schedule, protocols in place for rapid launch of a telestroke session, including priority access to CT scan, transfer and repatriation MOUs. This is what needs to be in place and critical for telestroke. But also, this is why the example of Canada is very good. Telestroke is not only about thrombolysis, it's after thrombolysis and what is done in case of non-thrombolysis. Rehabilitation, home care community should be put in place, and virtual stroke education is definitely needed. After the excitement of, yes, telestroke is affordable for our countries. Yes, it's a need, but it's also affordable. We need to discuss some barriers. Cross-border barriers, regulation data. Yes, indeed. A neurologist in one country is not often legally advised to take care of a patient in another country because medical licensing remains national, not regional. Cross-border telemedicine liability is often undefined in law. And most important, the reimbursement models rarely account for remote consultation. Who will pay? And then how the money should be sent to a country from another. Are the rates the same in different countries? And that are many things should be discussed and could be set as a big challenge. Data sharing agreements between health ministries are limited. Requirement for harmonization, mutual recognition of specialist credentials for telestroke consult. That is important to set in place before. A regional legal framework defining liability and standard of care, harmonized data protection rules for cross-border patient imaging, cross-border barrier data infrastructure. Connected care needs connected system, indeed. And today, imaging platform records and network rarely speak to each other across border. Connectivity gaps, rural and border facility often lack the bandwidth for reliable video and large imaging transfer. Language and terminology spoken language across may complicate the sharing of protocol. Incompatible record, non-standardized electronic health record make rapid history sharing difficult. Data governance, inconsistent cybersecurity and privacy standards, slow cross-border data agreement. Cross-border barrier for cross-distribution. Yeah, even with perfect technology, telestroke only works if trained specialists are there to answer the call. Too few exist where there is a need. Here is a repartition of countries where there is a neurologist. It's from WFN side. And this is the amount of neurologists by countries. And you see Egypt is the country where the most neurologists, and Algeria and South Africa follow. But this is, we see here more than 100 for a population up to 200 million. Here in Gabon, there is 15 neurologists for a population of 2 million. So don't only stuck on numbers, but we need to see the density. Another barrier is on workforce distribution. Uneven distribution, vascular neurologists cluster in capital cities, leaving whole peripheral cities uncovered. It's also difficult to have centers guarantee night and weekend specialist availability. Training bottleneck. This is a real problem, especially for our region with many languages and people are not eligible to be trained in different languages. Retention pressure. Our roadmap for set up a telestroke unit, a single interoperable telestroke network spanning our health system, connect regional association, build and share protocols, and open the every hospital willing. Good job. Our roadmap in 3 phases. At year 1, adopt protocol from PAUNS-AFAN. Year 2, set up a pilot and probe, and after the year 3, scale regional open network membership across PAUNS-AFAN. In conclusion, a small take-home message. First of all, stroke care is a race against time, and African and Middle East specialist access gap cost precious minutes every day. Telestroke is proven technology. It cuts treatment delay and lowers mortality wherever it's deployed. Regulation data and workforce barriers are real, but they are solvable through regional coordination. Regional organization might position to lead a telestroke network, starting with a focused pilot. I would like to finish with this quote of Maya Angelou saying, do the best you can until you know better. Then, when you know better, do better. Ladies and gentlemen, mesdames et messieurs, I would like to thank you for your attention.
Thank you, Dr. Michel Arnaud, for this presentation. Very clear and excellent. And we present now the last presentation will be made by Professor Hatem Semir, presentation on extending access to non-pharmacological intervention in neurology from rehabilitation to brain stimulation. Professor Hatem Semir Shahata is Professor of Neurology in Cairo University, Egypt, He's obtained his medical degree in neurology from Cairo University in 2001 and has completed specialized training in neurorehabilitation and botulinum toxin therapy in Italy, the United Kingdom, and Denmark. He currently serves as Secretary General of the Egyptian Society of Neurology, Psychiatry, and Neurosurgery, and is a member of the MS Care Egypt and a member organization of the Multiple Sclerosis International Federation. His clinical and research interests focus in multiple sclerosis, focal dystonia, headache disorder, and significant neurorehabilitation program. Professor Shahata has author and co-author of numerous peer-reviewed. Professor Samir, the floor is yours.
Good afternoon, my distinguished professor and colleagues. It's my great pleasure to join you in celebrating World Brain Day. Today, I'd like to share how non-pharmacological interventions in neurology can transform neurological care and rehabilitation. This is my disclosure. To start with, neurorehabilitation is not simply about recovering movement. It's about believing in the brain capacity to change before the change becomes visible to us. They say seeing is believing, but sometimes the most real things in our world are what we cannot see. In neurorehabilitation, that's exactly what we do. We don't just treat what is visible. We work to restore what cannot be seen. First, like neural connectivity, like plasticity, and so on. For this patient with DTI performed twice with 1 year apart, after 1 year of his rehabilitation, DTI revealed what the eyes couldn't see. Here, there is about 10% of microstructural recovery of the spinal cord. Rehabilitation made the invisible things visible. We cannot see before what's going on in the spinal cord, and the MRI is always the same. But with DTI, we saw some improvement over 1 year, going hand in hand with improvement in the functional capacity of this patient. Neurological disabilities resides in many dimensions, like speech, sensory, motor deficit, coordination disorder, bulbar paresis, visual, hearing, mood, behavioral disorders, and cognitive domain deficits. So we need a long-term, lifelong, maybe, problem-solving process to obtain an optimum function despite residual disability, to optimize function, participation, and minimizing the caregiver burden, and reducing residual disabilities and maximizing the behavioral repertoire of the patient. Rehabilitation, one size never fits all. Every patient is unique. It's like snowflake with different impairment, goals, and life circumstances, different combination, making every patient is unique. And we have to tailor and individualize our strategies to address the specific barriers for each patient to improve the daily activity. We may need physical therapy, occupational therapy, vocational rehabilitation, cognitive rehabilitation, and SSP. This patient is videotaped on June 2019. He has traumatic spinal cord injury with spastic paraplegia affecting the right side more than the left side. He came to Cairo for rehabilitation. And in 2025, this is his picture. He was walking. And how does this occur? We will see over the presentation. True recovery restores the original motor pathway through adaptive neuroplasticity, allowing same muscle to produce normal movement. On the other hand, to be realistic and to be more practical, the International Classification of Functioning Disability and Health defined it as improvement in the performance. It's a new alternative motor patterns, the different muscles with alternative or compensatory motoric pattern. This is another case scenario to differentiate between acute neurology and rehabilitation. In acute neurology, our priority in this patient is survival. We are worried about hematoma expansion, about intracranial pressure, hydrocephalus. But 3 months after survival, the patient has another issue, another problem. He has mild weakness in lower limb, but he has the main problem in his hand. And this is what was his problem. He has spastic closed fist. He cannot use his hand. And that was his main problem. And we have to target this problem for better participation in environment. One of the greatest paradigm shifts in neuroscience is that the brain is not a static organ. It's dynamic and continuously adapting itself. Neuroplasticity is the ability of the brain to reorganize both structurally and functionally itself to respond to injury. And this is the biological basis of recovery. It's a continuous process allowing short-term and long-term modification of neuronal synaptic maps to enhance the function of the brain and the brain network. Instead of the traditional Penfield representation of brain areas with fixed and non-overlapping parts of the brain, we now know that motor representation is highly dynamic, interconnecting with overlapping zones and heavily cortical connections with ability to modify itself for more functional recovery after neurological injury. Neuroplasticity extend beyond individual brain region, even at rest in idle moments. Distant brain areas remain functionally connected through intrinsic networks, which is the resting state network. And functional MRI using Ball technique detects these spontaneous low frequency fluctuations, allowing us to visualize the brain functional connectivity without performing any task. With this concept, brain forms cohesive modular architecture with different modules, somatosensory, visual, attentional, and limbic and paralimbic systems. It's arranged in 5 modules. And this figure shows the rather functionality of the brain. It's not an isolated centers. The brain operates as interconnecting functional modules, and the balance between specialization within the modules and communication between them allows the network to reorganize after injury. This is the principle that marks neurorehabilitation and makes it possible. In our functional connectivity and plasticity and investigating the functional connectivity, it reveals a long-range alteration in cortical activity induced by brain lesion. It's not only the site of the lesion, but also the size and the hub type, whether it's connecting part within the same module or it's a more global hub that connecting one module with another one. Functional recovery occurs in two stages. First, subtraction, where the damaged connection and inefficient connection is suppressed, and then reorganization occur in which surviving networks establish new functional connections and maybe structure connections and compensate for the lost pathways. The plasticity level and mode of recovery is autonomous with the structural and functional and guided, and this is what we performed with our patient, whether pharmacological and non-pharmacological, to enhance the structural and functional plasticity. We will talk about the non-pharmacological, including the rehabilitation, the non-invasive stimulation, and PCI. Structural plasticity occurred whether with cortical remapping with parallel pathways or Hippian learning, axonal sprouting and arborization to form new synapses, and neurogenesis with neuroplasts in the neurogenic niches, like in subventricular zone and dentate gyres. There are few drugs with evidence for efficacy in neurological recovery. We don't have class 1 evidence at all, but we have some drugs like amphetamine, levodopa, methylphenidate, SSRIs, donepezil, and rivastigmine, and maybe memantine. But all these drugs are not approved and not evidenced for rehabilitation. Neuromodulation uses targeted electrical or magnetic stimulation to define neural activity and enhance recovery. I think this is the basis of neuromodulation. It's increasingly used for movement disorder, for post-stroke, spasticity, weakness, neuropathic pain, spinal cord injury. However, some challenges in using neuromodulation, like financial resources and need of adequately trained personnel, are main cornerstone blocks in widely using the neuromodulation. The most widely used one is RTMS, that causes long-term potentiation or inhibition according to the way of use it. It enhances metaplasticity and activating the feedback loops. It's relatively affordable with multi-use in various neurological disorders like freezing of gait, especially the on-freezing, ataxia, and chronic migraine. We have some experience about ataxia and chronic migraine, and it's FDA approved for depression. Whether the high frequency that cause cortical excitability or low frequency with inhibitory effect, it will modulate the cortical activity during the session and shortly after the session. It causes unmasking of the parallel pathways, and it alters the corticospinal excitability. Here in this figure, we show that after unilateral lesion, the balance between the two hemispheres is disrupted. The unaffected hemisphere becomes overactive and excessively inhibit the injured one. So neuromodulation aims to restore the balance between the lesioned hemisphere and the other one, whether by inhibited the contralesional hemisphere by low-frequency RTMS session or exciting the epsilesional hemisphere, thereby enhancing corticospinal transmission. Other neuromodulation like spinal cord stimulation, which is FDA approved in chronic limb pain, it changed the nerve conduction property with modifying the functional and anatomical organization and block the gate control of pain. It also promotes some studies reported some effect on oligodendrocytic precursor cells that may lead to remyelination. The other option for neuromodulation is brain-computer interface, and we'll see this video first. When the patient says open, open, and when say close, it close. His hand obeyed his order.
Open. Close. Open.
And this occurs by EEG acquisition via electrode placement on a specific brain area, and then signals will be processed, and the received electrical signals are interpreted for their means by a means of a computer to direct any device, whether hands, leg, or whatever we need. This is actually present, and for many years, there are many studies about PCI. Other neuromodulation like sacral neuromodulation, posterior tibial neurostimulation for overactive bladder, and functional electric stimulation in feet drop. Now, rehabilitation could be bottom-up targeted or top-down targeted. And rehabilitation is very crucial for promoting plasticity, in addition to neuromodulation and maybe pharmacological treatment. The top-down targeted neuromodulation and neurorehabilitation is either training with a mirror while moving the unaffected limb. The patient watch its mirror image as it were the affected arm, and viewing the mirror reflection facilitates ipsilateral motor cortical excitability, and the virtual reality with a multimodal, interactive, and realistic three-dimensional environment. This is a patient on February 2023. This is in July 2025. The patient underwent an extensive rehabilitation plans with multiple cycles of botulinum toxin injection. He received also RTMS sessions. To recap, to signpost towards better rehabilitation plans to improve functionality following injury, short, intermediate, and long-term strategies should be adopted, and these strategies should be individualized for each patient, as everyone is a distinguished script. We have to choose the most appropriate strategy for everyone. The main message is that brain is not immutable. Dysfunction at a given point will not be static, and the brain will be dynamic and adaptable. And this is a basis of neuroplasticity. Brain functional networks have an intrinsically cohesive modular structure arranged in different hubs rather than the static one, and proper use of all modalities of rehabilitation techniques is crucial to maintain improvement and prevent the maladaptive plasticity. Lastly, thank you.
Thank you to everyone. I hope that you enjoy this joint AFAN PAUNS webinar. And as you see, the theme access to care is very important. And I hope that these interventions contributed to improve access to neurological services, essential medicines, and innovative solution, which remain a solution and a global priority for people with neurological diseases.
Thank you, Iman. I have to thank the two organizations, the PAUNS and AFAN, for the huge work. As it was outlined by the introductions of Professor Lewis, Gargouri, and Taka, brain health will be the main theme in neurology in the next years. It is already. And as it was outlined also by the presentations, there's a lot that have been done in Africa and the Arab world, but there's a lot also that must be done. We are still far from offering brain health access equal to all our population in these regions. This is very important theme, and this is a work that we in the Strategy Brain Health Commission of the WFN will work on it. Make this work a common work. And I hope that we will be able in the next year with the IGAP and with all this activity by the WHO, by the WFN, by the regional organizations to offer to our patients the care they deserve. See you soon in the e-learning day, which will be the 12th of December this year, and it will be on headache and migraine with the SHIPAC. See you soon and keep in touch.